Assalamu alaikum, everyone. I hope everyone can hear me clearly. Uh, I'm Dr. Sarah Sadaf. I will be the host of this session. I'm working as Associate Professor and Head of Department at Sheikh Zayed Medical College and Hospital, Rahim Yar Khan. And I will be your host as well as the facilitator of this session today. So I welcome you all on this virtual training session of landmark guided peripheral nerve blocks for acute pain. The esteemed faculty from different cities will be joining us today as facilitators and guest speakers. So first of all, I will introduce Dr. Mamoona Shaikh. She is working as assistant professor at Liaquat University of Medical and Health Sciences, Hyderabad and Jamshoro. My respected colleague, Dr. Mamoona Shaikh, will be our second facilitator. We will have Professor Dr. Haddad Durrani. He is Director Medical Education and former Head of Department Anesthesia at Allama Iqbal Medical College, DG Khan. Dr. Nurunisa, shortly she will join us. She is ITU and Anesthesia Specialist at Marsden Hospital, London. Then Dr. Jamal Humayun Khan, he will be joining us. He is Consultant Pain Physician and Head of Department at PAF Hospital, Miawali. Dr. Umar Saeed, he is Consultant Pain Physician and Head of Department and Social Security Hospital, Lahore. So I'm really grateful to all the faculty who has already joined and some of will be joining soon. So that's about the faculty. Now about the session. This online session will have two presentations and that will be followed by video recorded demonstrations of landmark guided peripheral nerve blocks. Then we will have question and answer session with you all. And for that, I will invite our guest faculty to answer your queries.
Madam, can you hear me?
Yes, I can hear you.
Okay, and can you see my screen?
Yes, I can see your screen.
Okay, so I'm sure we all are very well versed with our today's topic, which is landmark-based technique or landmark-based blocks. Okay, and again, I'm Dr. Mamoona Shaikh, working currently as assistant professor at this beautiful place in the Department of Anesthesiology, Critical Care, and Pain Medicine. So, written that now it is here that superficial cervical plexus has its origins from only the ventral rami of C2 to C4 nerve roots. But the drug could spread to different areas depending upon the volume. So you need to be very careful in this area. This is a beautiful picture from Nysora. As you can see here, this is the mastoid process. This is the thyroid cartilage. And this huge strap of muscle is the sternomastoid muscle. And this is posterior border of the sternomastoid muscle from where the cervical plexus emerges. And this thick structure, this is the external jugular vein, which crosses the midline of this muscle anteriorly. So you need to be careful about that. Now, these are the four important nerves that we are trying to target in this block. This block will block the sensations from skin and superficial structures of the pinna, the acromioclavicular joint, clavicle, and whole of the anterolateral neck. So as you can see in this picture, that this whole area, colored area, will be blocked. And the individual area supplied by each nerve is also shown in the picture. So you could see that majority of the pinna is covered, the submandibular region, anterior and lateral part of the neck, including the clavicle and some part of the shoulder as well. Now, what are the indications for this block? As I have told you, for superficial neck surgeries like carotid end arterectomies, it has been a novel technique. For lymph node dissections in the cervical region, for thyroid and parathyroid surgeries, although for beginners, I would not recommend it, but you could use it for post-op analgesia. And of course, for biopsy of cervical lymph nodes. Then for trauma and laceration repair in the anterolateral neck. Now, in our department, the most common indication for this block is central line placement, not just in the theaters, but in the critical care setups as well. Then for pain management in certain chronic conditions involving the neck and shoulder region. In OMF surgery, any procedure involving the submandibular or the perimandibular area could be done in this block. Apart from that, it could be used for thyroglossal and branchial cyst surgery, and it is used as a component of regional anesthesia for shoulder and clavicle surgeries. Now here you can see that the shoulder is also supplied by these nerves, the supraclavicular group of nerves. So it also provides some analgesia to the shoulder, and along with interscalene brachial plexus block. This block also supplements shoulder analgesia. Now, apart from the routine contraindications, the contraindications very specific to this block are if the patient is having contralateral phrenic nerve paralysis. So if you are giving a large volume in this area, it could block the ipsilateral nerve, and then you could have a problem. Then previous neck surgery and neck radiation, because the anatomy gets distorted and the blocks are landmark based, so you might face a problem. Caution must also be exercised in patients who suffer from severe chronic obstructive pulmonary disease or an untreated contralateral pneumothorax. The complications specific to this area include injury to the major vessels, recurrent laryngeal nerve blockade, which could make the patient hoarse for some time, inadvertent brachial plexus block, and inadvertent accessory nerve block leading to winging of scapula due to weakness of the trapezius muscle. Here you can see that the vessels lie very close to the needle insertion point. So you need to be quite careful. Now, the only term that I need you to focus on in this whole of the slide is this needle fanning technique written in green color. This is what it means. After piercing the skin, you have to fan your needle in all directions, superiorly, inferiorly, and posterior to the sternomastoid muscle and inject in each direction. Now, these are the landmarks shown in a volunteer. This is the mastoid process. Can you see my arrow?
Yes, we can see. Yes, yes.
Okay, thank you. So this is the mastoid process. This is the posterior border of the sternomastoid muscle. Now, in some obese patients, you might face problem that you cannot feel the muscles very well. So what you do is that you place your hand on the forehead of the patient and ask them to lift their head against resistance. This is going to make their sternomastoid muscle prominent, and then you can mark the posterior border. Now, this is the thyroid cartilage or the Adam's apple, usually quite prominent and easy to palpate. And you will draw a line from here up till this mark. When the two lines join, just posterior to it will be our needle entry point. This is shown very beautifully in this picture. Okay, so this picture shows the landmarks that we've already discussed. And the fanning technique is shown here. So you see, first the drug is being injected inferiorly, just behind the posterior border. Then the needle is rotated into the superior or the cranial direction. And again, some local is injected in that direction. And then the needle is advanced behind the posterior border of sternomastoid muscle. And a little bit of local is injected over there. So this is the typical fanning technique. Also important is that the needle has been bent slightly so that you do not introduce the needle more deep inadvertently. Okay, so this is a study conducted in 2010. And it was a randomized comparison between ultrasound-guided and landmark-based superficial cervical plexus block. What they concluded in this study was that ultrasound guidance does not increase the success rate of superficial cervical plexus block compared with a landmark-based technique. So there you have it. You can easily perform it based on the landmarks. The second block that I'm going to talk about is the erector spinae plane block. Now, just you need to understand that erector spinae is a group of three muscles, iliocostalis, longissimus, and spinalis. They run bilaterally from skull up to the sacrum and medially from spinous processes up to the transverse process and extending to the ribs in the thoracic region. They are part of the core muscles, and one of their main function is to stabilize the spine. Now here you could see, if you remove the trapezius and the lats dorsi muscle, you will see the group of three muscles over here, and together they are known as erector spinae muscle group. And they run bilaterally from cervical region up to the sacrum. So it means we can perform this block either in cervical region, thoracic, lumbar, or sacral areas, depending upon our indication. So what are the indications? They can be divided into acute and chronic pain conditions. When talking acute, they are used for intra-op and post-op analgesia and analgesia for rib fractures. Now, there is a huge array of surgeries for which this block is used. As I've already mentioned, it can be placed in different regions. So it can be used for thoracic surgery, abdominal, lumbar, gynecological, orthopedic surgeries, even for lower extremities as well. It has been a novel technique for rib fractures, and it is also emerging as a novel technique in chronic pain conditions like neuropathic pain, CRPS type 1 and 2, failed back surgery syndrome, cervicogenic headaches, and for metastatic bone pain. This is a meta-analysis which showed the use of ESP block in pediatric population, the youngest one being 6 months old. And this row shows the huge array of indications ranging from tumor of the ribs, open thoracotomies, then nephrectomies, inguinal hernia, laparoscopic cholecystectomies, and DDH. So it is a very useful block and very easy to perform. Now, another useful and beautiful tip for this block is that it can be performed in any position, prone, lateral, and sitting. The sitting position is usually very easy to identify the landmarks, especially for the beginners. So what you have to do is pierce the skin, traverse the whole of the erector spinae muscle, hit the transverse process, and inject the drug in between these two structures. The idea is that the drug is going to move forward and laterally to block the dorsal as well as the ventral rami. Again, after piercing the skin, we have to hit the transverse process and inject the drug over here. Now, the transverse process also gives us some protection against pneumothorax. This is how you need to first place your markings, since we are talking about landmark-based technique, but you need to understand that what level corresponds with which vertebra. So we all know that C7 is the vertebra prominence. It is at the back of the neck. Then the spine of the scapula corresponds to T3 level. The tip of the scapula corresponds with T7. The Taffier's line or the top of the iliac crest corresponds to either L4-5 interspace or the L4 vertebrae. And then the posterior superior iliac spine corresponds with the sacral, second sacral vertebra. So this is how you mark your landmarks. This is the vertebra prominence. This is the scapula. This is tip over here. And therefore, this is the T7 level. This vertebra is the T7. Here, if you are going from above, from below, then at the Taffier's line, this is the L4 vertebra, and you can start counting upwards and decide your level according to your indication. Now, once you have marked your vertebra and the level, you just have to move 3 centimeters lateral to it and put your needle perpendicular to the patient or the floor, whichever you are choosing. So this is the landmark. As I've already told you, this is the midline, and we are moving 3 centimeters laterally. The needle is injected perpendicular, and here you can see that the needle is being inserted perpendicular to the patient. The patient is in prone position, and after hitting the vertebra, we will inject our drug. So it is a very simple block with huge array of indications. Now, this picture shows that a single injection of 20 to 30 mils at T5 level will be going to cover 6 to 8 segments. So it is a very useful block. Again, I'm repeating it. According to the indications, if you are giving this block for thoracic procedures, then you need to give it at T5 level. If you are giving it for abdominal surgeries, you need to give it at T10 level. And if you are using it for lumbar or lower extremity surgeries or any other indication involving the lower extremity, then you need to give it at L3 level. Now, it is worth noting that this block is a little bit difficult for beginners at the lumbar region since there's a lot of bulk of muscles, the depth is more, as well as you need more volume to cover the equal segments as we spoke in the thoracic region. Now comes the fascia iliaca compartment block. Now, it is also known as an anterior approach to the lumbar plexus because it aims to block 3 nerves, the obturator femoral and the lateral femoral cutaneous nerve of thigh, which are the 3 main branches of the lumbar plexus. Hence, it is also sometimes known as 3-in-1 block. The indications are for analgesia, either intra-op or post-op analgesia, procedures involving hip, knee, and thigh, and the femur shaft, above knee amputations, and to address the tourniquet pain. For acute pain management, especially helpful for hip and femur shaft fractures and burns. In chronic pain conditions like cancer pain, it could be used very easily. In opioid IV abusers, it can be used to control the pain because they are very poorly reactive to opioids. Then in geriatric patients, for example, if they have hip fractures and they are not good candidates for surgery, rotational boot has been advised to them, then you can give this block to them to control their pain. It could be used in children for applying plaster cast to femur fractures in chronic inflammatory conditions. Apart from the routine contraindications, a person having femoral bypass surgery, you should avoid this block. It is contraindicated in those patients. So you need to keep that in mind. Now, this is a beautiful picture. The lumbosacral plexus is shown here. This is the lateral femoral cutaneous nerve of thigh. This is the femoral nerve. And this is the obturator nerve, but it runs behind this psoas muscle. So it becomes, sometimes it becomes a problem to block this nerve as well. And for that, we need to give larger volumes. These are the surface landmarks. Again, as described by Dr. Saira, you need to identify the inguinal ligament. This is the anterior superior iliac spine, the pubic tubercle, and you draw a line between these 2 landmarks and divide it into 3/3, 1/3, 1/3, and 1/3. Now you take a point between the medial 2/3 and the lateral 1/3, and you go 1 centimeter below it. You could see here. Now the femoral nerve block was being given at this area, but this is a slightly lateral point of injection. Although we do feel for femoral pulsations, just to make sure that we are not too medial or we are not going to puncture the vessel. And therefore, this is going to be our needle entry point. Here it is again shown the anterior superior iliac spine, the pubic tubercle, the line joining them, medial 2/3 and lateral 1/3, and just 1 centimeter inferior to it is our needle entry point. As you can see, this is our needle entry point and the obturator nerve is behind this muscle. So you need larger volumes to block this. But if your patient is having femur neck fracture and you do not need to block the adductor compartment, so you can spare this nerve. There is not a big deal with that. Now, this picture shows that when we are introducing our needle, we should feel for two pops, two distinct pops, just like the femoral nerve block. The first pop will be of fascia lata, and the second pop will be of fascia iliaca. So it is a two-pop technique, similarly to the femoral nerve blockade. These are the dermatomes in blue color, the myotomes, and the osteotomes. So you could see it has also a huge list of indications. Now, can you hear voice from the video?
No.
Dr. Saira, can you hear from the voice from the video?
No, Dr. Mamoona? No.
Okay. So I'm going to iterate it for you. Okay.
Yeah.
So this is a video showing the landmarks for the fascia iliaca. This is the pubic tubercle over here. This is the line joining this is anterior superior iliac spine. Now medial 2/3 and lateral 1/3 junction is taken. Then 1 centimeter inferior to it is taken. The femoral pulsation is being felt over here. And this is going to be our needle insertion site. Now some local is being injected because the patient is awake and we do not want the patient to be discomfortful. Okay. So this is our needle entry point. Now, in this picture, in this video, the block is being demonstrated. After identifying the needle entry point, piercing this is the first pop. Okay, now facial bounce and second pop. Now we are aspirating to look for blood, which is negative. The injection is easygoing without any resistance. There is intermittent aspiration. And then again, as you could see here, there is backflow of liquid, which is very important. This denotes us that we are in the facial plane and our injection is not intramuscularly. So it is a very important tip that you need to look for. The backflow of liquid should be your confirmatory sign that you are in a facial plane.
Dr. Mamoona, can you show the show the first video again where you were just localizing?
Landmarks?
Yeah, please, can you? Thank you.
Oh, sure. This is pubic tubercle. This is anterior superior iliac spine. This is the line joining them. Medial 2/3 and lateral 1/3 junction is shown. Then we are going 1 centimeter inferior to it. The femoral artery is being palpated and the injection side is lateral to it, as you can see in the video.
All right. Thank you so much, Dr. Mamoona.
Welcome. Okay, now coming to the rectus sheath block. Now first, we need to know what is the rectus mean. It is the anti-abdominal muscle, which we call the six abs or whatever. So it originates from the pubic crest and the pubic symphysis, and it is attached to 5th to 7th costal margins or the costal cartilages. It runs bilaterally in the midline. It is connected by linea alba. And this picture shows that the blue color denotes the nerves. So the nerves travel in the transversus plane, and after coming out of it, they enter the rectus sheath. This is the anterior rectus sheath, this is the muscle belly, and this is the posterior rectus sheath. Now, we need to insert our needle perpendicularly we will feel a facial bounce and then a pop, and then we will traverse our needle through the muscle belly. And when we are going to feel this second facial bounce, this is where we are going to inject our local anesthetic. We do not pierce this the posterior rectus sheath, because behind it lies the peritoneum and the organs. And besides that, the nerves lie over here, so we need to block them. Also, it is worth noting that the superior and inferior epigastric vessels run in the muscle belly, so you always need to aspirate before injecting your drug. Again, the list of indications is a large one, including umbilical and paraumbilical hernia repair, epigastric hernia repair, midline laparotomies, laparoscopic surgeries, gynecological procedures, abdominoplasties, and some chronic pain conditions like myofascial pain syndromes and cutaneous nerve entrapments. So this picture shows the landmarks, surface landmarks. This is the Xiphi sternum marked over here. This is the umbilicus. This is the cranial end and caudal end of the patient. So this is common sense, the midline of the patient, which is very easily identified. What we have to do is just move 3 centimeter laterally, and this is going to be our injection point. We have to insert our needle perpendicularly. So this is a video demo again for the landmarks. We can skip that. Okay, so this patient came to us with dehiscence of the midline laparotomy. The laparotomy had been done 3 months back, but since then he was having pussy discharge, and finally he went into wound dehiscence, and he presented to us being very malnourished, very wasted, with a scaphoid abdomen, was septic, and the surgeons were planning to reopen and do a midline laparotomy. And the first reading, even after optimizing this patient, the first systolic reading was 87 millimeters of mercury. So definitely, this patient was not a good candidate for epidural analgesia. And so we chose the rectus sheath block for this patient. He was very much wasted, and also he was septic. He had labored breathing. So you can imagine that opioids would also not be a good choice in this patient. Also, this patient was having gut protrusion through the wound dehiscence. So we were planning to place the bilateral rectus sheath block. You could see the midline. This is the umbilicus. This is the cranial end of the patient. So 3 cm from the midline, the skin was punctured. We were using a blunt tip needle, the facial bounce, then first pop, then the second facial bounce, and this is where the drug is injected. Now there had been negative aspiration, and then you are going to inject the drug, and you need to keep aspirating after every 3 to 5 mils of local injection. And after that, another 10 mils will be given, as you can see in the video. Okay. So the first 10 mils have been given. Now the second. Now here you can see the backflow. We are in the facial plane. It has been confirmed by backflow of the fluid. Again, negative aspiration. The drug is moving easily without any resistance. So you can see it is a good choice in this patient when epidural is not a good choice in such patients. Now, this block is performed bilaterally to cover the midline incision. The block is being performed on the second side. Again, 3 cm laterally. First pop, then the facial bounce and negative aspiration. The drug is moving easily without any resistance, negative aspiration intermittently, which is very important, keeping in mind the superior inferior epigastric vessels. And the fluid is coming back, and then the second syringe is attached and 20 mils are given on the second side. Okay. So there are two thoughts. One is that you inject 20 mils on each side, while some clinicians suggest a 4-point injection technique for better coverage, and they advise 10 mils of LA at each injection site. The reason being that there are tendinous insertions within the rectus muscles, so it is better for better coverage. It is quite recommended to use this 4-point technique. Now, another point worth noting is that the area from this umbilicus and to the pubic symphysis, when it is divided into two halves, the inferior half has the fascia transversalis only, and the posterior rectus sheath is deficient over here. Now imagine yourself that you're sitting inside the peritoneal cavity and you're looking anterior wall of the abdomen. So you can have a better idea of this image. There is a deficient rectus sheath posteriorly. So we do not perform this block below umbilicus so that we inadvertently pierce the fascia transversalis and injure the intra-abdominal organs. Another special tip regarding this block is that the rectus extends more laterally than we often think. Hence, this block is easy to perform even with dressings on in the post-op period, especially as a rescue block in post-anesthesia care unit or even in critical care units. This is a 2015 study where they compared the rectus sheath muscle, rectus sheath block with the epidural. And what they concluded was that rectus sheath catheters provide equivalent analgesia to epidurals following laparotomy for colorectal surgery. So it does provide quite good analgesia. Now, this is the final block of our today's talk. This is the transversus abdominis plane block. And as you know, this block will cover the area supplied from T7 up to L1. And these nerves also supply the costal parts of the diaphragm, the related parietal pleura, as well as the parietal peritoneum, along with the anterior abdominal wall, skin, subcutaneous, and the muscles. So this is a very beautiful diagram. If you see here, if you need to give the rectus muscle, rectus sheath block, you are going to inject your drug over here. If you need to give erector spinae block, you are going to inject your needle and insert your needle here and inject your drug over here. While for TAP block, you need to give your local anesthetic between internal oblique and the transversus abdominis muscle in this plane. Now, the indications are huge. Examples include abdominal surgeries like hernia repairs, appendectomies, cesareans, procedures involving abdominal wall, open cholecystectomy, nephrectomies, etc. It is also used for laparoscopic surgeries or when epidural anesthesia is either contraindicated or is not preferred. It is always used as a multimodal pain regime. You do not use it as a sole anesthetic or analgesic agent because this block, along with the ESP and the rectus sheath block, supply the anterior abdominal wall and they provide analgesia only for that. There is no visceral analgesia. And for that, you need to supplement the analgesia with either paracetamol or some NSAID. It is also used for certain chronic pain conditions like nerve entrapments or post-surgical neuropathic pain. or for other chronic conditions, regardless of the cause, it may be tried in those conditions as well. The complications specific to this block are peritoneal perforation, bowel injury, and block failure. Now, there is a very good reason why this block usually fails. And I'm going to demonstrate that to you in a minute. The tab block is of two types, the subcostal tab and the posterior or the conventional tab. These two blocks are differentiated by the location of injection and the area of analgesia they provide. The subcostal tab is typically used for upper abdominal surgeries, while the posterior or the conventional tab is used for lower abdominal surgeries. So let us first discuss the conventional tab block. It is placed in the triangle of Pettit. What is the triangle of Pettit? We are going to discuss it in a minute. So this is the reason why this block usually fails. Now what happens that we need to give this block in the triangle of Pettit over this area so that it covers the anterior and the lateral cutaneous branches. However, most of the people or most of the beginners make the mistake of giving it quite anteriorly, although they feel two pops, but as you can see that they only block the anterior cutaneous nerve. The lateral is spared. So it is the most common reason for this block to fail. Now, this picture shows the triangle of Pettit that we are interested. This is the iliac crest. Anteriorly, it is bounded by external oblique and posteriorly by lats dorsi. And this triangle is our site for needle entry. Okay, and it coincides with the mid-axillary line. So mostly this triangle of Pettit is difficult to appreciate. And so there is a minor variation in this, that first we are going to palpate the anterior superior iliac spine, which is quite easy in almost every subject or every patient. And then we first move 5 centimeters cranially and then 5 centimeters posteriorly. So this will roughly coincide with the triangle of Pettit, and it is going to be our needle entry point. So I have deliberately chosen a very healthy subject, as you can see. This is the costal margin. This is the iliac crest. Now, definitely it is very difficult to palpate the triangle of Pettit or identify it, since you could see that it is a very bulky area. So what you are going to do, you need to identify the anterior superior iliac spine, and then 5 centimeters above and 5 centimeters posteriorly. Now you could see that this roughly coincides with our triangle of Pettit, and it also lies with the mid-axillary line, and this is going to be our needle entry point. So here the landmarks are again shown. This is costal margin, this is anterior superior spine, 5 centimeters above and 5 centimeters posteriorly. This is the cranial end, this is the caudal end of the patient. Okay, so this is a video demonstration of the landmarks again. I think we do not need to repeat it again. Okay, so one more important point is that now, since we are talking about the Pettit's triangle, you need to understand that the external oblique makes its anterior margin and it is not present in this triangle. So you are only looking for a single pop. Again, you could see here, if you are giving the tab block in this region, slightly anteriorly, there you will feel two pops, one over here and the other one over here. But if you're giving it in the Pettit triangle, you will only feel a single pop, and this is where the nerves lie. This is the video of the tab block. This patient was scheduled for hernia repair, inguinal hernia repair. So this is the anterior superior iliac spine. This is the costal margin. Now from ASI's 5 cm above and 5 cm posteriorly. Now, this is the landmark for our needle injection or needle insertion. Now, this is a blunt tip needle, so there is considerable resistance. So after piercing the skin, we are going to see the fascial bounce. Now we will feel a single pop. And after the single pop, and then you're going to inject your drug. There is negative aspiration. The drug is moving easily without any resistance. This was 0.15% bupivacaine for analgesia purpose. The point had already been identified and local was already given. Now again, to demonstrate the single pop technique, this is the fascial bounce and this is the pop there. And negative aspiration, the drug is injected quite easily without any resistance, and 20 mils are given for hernia surgery. Now, the fluid is coming back, which means we are in the correct facial plane and the drug is not intramuscular. So a single injection in the conventional or posterior tab is going to cover T10 to T12 or L1 area. Again, one more point which is important to consider is that since this block was given for hernia repair, it was given unilaterally. However, for a surgery in which the incision crosses the midline, you need to place this block bilaterally. Now, the subcostal tab block is also known as oblique subcostal tab block, but this term is usually reserved when this block is being placed ultrasound guided. So when ultrasound is used, the block is placed just lateral to the end or lateral edge of the rectus muscle, while with the landmark technique, we are usually giving this block at this position where you will feel two pops, one over here and the other over here, where we will inject our drug. These are the landmarks. So what are you going to do? First, you need to identify the costal margin. Then the anterior axillary line. Now, these two things are very easy to identify in any patient. And you can see this is quite an obese patient, but still the costal margin could be felt and the anterior axillary line is also easily identified. Then you need to go 3 centimeter anterior to the anterior axillary line and just below the costal margin. And this is going to be our needle insertion point. So this is again a video demonstration for landmarks. And this is a video for subcostal tab block. The costal margin is palpated and the anti-axillary line has been identified. We will move 3 centimeter anteriorly and place our injection just below the costal margin. After piercing the skin, this is the first pop. This is the second pop. Okay, then aspiration is negative. The drug is being injected quite easily without any resistance. Again, intermittent aspiration and done. Okay. So this 20 mils are given on each side. You can go up to 30 to 40 mils, but usually 20 mils can do the trick. Now, this patient has already been operated for laparoscopic polycystectomy. There is backflow of the drug, again confirming that we are in the facial plane and not intramuscularly. Then the block is repeated on the next side. Because the incisions are crossing the midline, we also need to cover the umbilical port. So again, 3 centimeter anteriorly to the anti-axillary line, just below the costal margin. The first pop, then the second pop, and also notice how the needle is being, fixed against the skin so as to avoid inadvertent movement of the needle. Okay. So if there are large incisions, for example, surgeries involving the liver, spleen, or the pancreas, where the surgeons usually place the T-shaped incisions. So you can combine both the subcostal and the conventional tab block, and this will provide from T7 up to T12 or L1, and this whole area could be blocked. But it is worth noting that since you are giving large volumes, almost up to 80 mils, 20 over here, 20 on this side, and similarly 40 on this side. So you need to keep in mind and check yourself for the toxic dose limits. So this is a beautiful picture comparing the area coverage with the rectus sheath block, the subcostal tab, and the conventional tab block. Okay, so let us do the SWOT analysis of all these blocks. What were their strengths, weaknesses, or any other special tips that we need to consider? The volume for each block should be discussed. For superficial cervical plexus, usually 5 to 10 mils. For ESP, 20 is usually enough. For fascia iliaca, 20 to 30. Some clinicians may go up to 40 mils to make sure that the obturator nerve is also covered. For rectus sheath block, 10 mils if you are doing the 4-quadrant technique, or if you're giving a single injection on either side, then 20 mils on either side. And for tab block, again, 20 to 30 mils for each side. How many number of pops are we expecting? None for superficial cervical plexus and ESP block. However, 2 for fascia iliaca compartment block, a single for rectus sheath block. We do not need to pierce the posterior rectus sheath. Then when we are talking about the tab block, we need 1 pop for the conventional or posterior tab and 2 for subcostal tab. Does these block provide surgical anesthesia? For superficial cervical plexus, yes, but no for all other. Now, there is some caveat in the fascia iliaca block, but for new learners or beginners, I would say that use it for analgesia purpose only. Is it placed unilateral or bilateral? Superficial cervical plexus can be placed bilaterally depending upon the indication. If you are using it for central line placement, definitely you are going to give it only on that side, ipsilateral side. But if you are giving it for post-op analgesia, for thyroid surgeries, then you need to place them bilaterally. ESP, again, if you are going for mastectomy, then you need to place it on that side only. But if you are giving it for cesarean, then you need to place it bilaterally. Fascia iliaca, again, is given on the ipsilateral side, but sometimes given on both sides, for example, in polytrauma patients. So you can give in those patients, you can give in both limbs, but you need to, again, check and balance the toxic dose limits. Then the rectus sheath is always given bilateral, never on one side only. For tab block, again, depending upon the indication, if you are giving for appendectomy, for hernia, for open coli, you can place it on that ipsilateral side. But if you are giving it for cesarean or for laparotomies, for laparoscopies, then you need to give it bilaterally. With that, I thank you for your attention, your patience, and your precious time. Over to you, Dr. Saira. Thank you.